Hello, everyone, and thanks for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name's Professor Peter Nash from Griffith University, beautiful downtown Brisbane, and today we're very fortunate to be joined by Dr. David Kellner, who's an IGNITE-MSCR Fellow of the Division of Rheumatology from the UCLA Medical Centre in the US of A. Thanks so much for joining us. And today we're going to talk about a very topical issue in rheumatology across all immune-mediated inflammatory diseases. It's a recent article that David and Professor Ranganath published in ACR Open Rheumatology in the September edition of this year. So it's hot off the press. And it's looking at the effect of the GLP-1 agonists on patients with rheumatoid arthritis. And a very hot topic, we've seen it reduce pain in knee OA. We've seen it improve gout flares. We've seen it improve lupus nephritis. We've seen it in lots of areas. And it's a very popular, exploding area because obesity and diabetes is starting to head towards 30%, 35% of patient populations in many countries, as we have seen in recent publications. So, welcome, David. Can you tell us a little bit about yourself and where you work and what you're working on?
Absolutely. Thank you so much for having me. It's a pleasure to be here. So yeah, my name is David Kellner. I'm a rheumatology fellow at the University of California, Los Angeles. I'm currently working toward my master's in clinical research, and I'm working with my mentor, Dr. Veena Ranganath, and my interest is at the intersection of obesity and inflammatory arthritis. I also have a keen interest in ultrasound and using that as a tool to assess inflammatory arthritis. And so this study kind of plays into my research interest, and I hope to
Excellent. So,
build on it. Yeah.
excellent. So, tell us a little bit about the objective, what you tried to do in this particular study, because in many ways it was very cleverly done. What did you do?
Right. Well, just to start off, kind of the motivation for the study, obesity is a common comorbidity in rheumatoid arthritis, and it's associated with higher disease activity, in addition to increased cardiometabolic risk in these patients. And my mentor, Dr. Ranganath, recently performed a randomized trial with a diet intervention showing that, short-term weight loss through diet helped improve patient-reported outcomes and decrease inflammatory markers in these patients. And so, now we have this class of medications, as you mentioned, the GLP-1 receptor agonists that are highly effective for weight loss and for decreasing, diabetes and cardiometabolic risks. But they have not been well studied in rheumatoid arthritis patients and other kind of patients with rheumatic diseases. And so we wanted to see if these medications, do they, as we would expect, do they improve obesity and cardiometabolic risk factors? But B, could they also potentially impact rheumatoid arthritis disease activity and other important metrics such as, patient pain and patient-reported outcomes?
Okay, so the clever thing about what you did, and this is a retrospective single center study, we understand that, and you followed them for 12 months, and perhaps that wasn't long enough, but it's a start. You took 229 RA patients who were already prescribed GLP-1 antagonists. And one of the questions is, what were they being prescribed for? At least 50% were diabetics. So I imagine that was a principal driver. But you compared 173 of them who took the drug with 42 who didn't, to act as a very nice control. And which GLP-1 agonists did you study?
We studied semaglutide, both its subcutaneous and its oral form, and also subcutaneous tirzepatide. And these are both by far the most commonly prescribed currently in our system.
Okay. And you unfortunately didn't have disease activity scores to look at, or even, and you made up your own scores. Can you tell us a bit about that? And it would have been nice if you could have tested a few patients who had disease activity scores against your made up score and see if it had credence.
Yeah, no, that's a great point. And unfortunately, we just didn't have very many CDIs or DAS-28s, and that might be a quality improvement project to get those more regularly recorded in clinic. But to do the best that we could, we had two people independently review each clinic encounter and assign a category, be it remission, mild, moderate, or severe disease activity, based on the clinic notes, based on if they said, if they happened to say if they had new, swollen joints or if they gave a joint count. But it is, like you said, an imperfect way of doing things. We really wish we had the CDI or DAS-28. And I think that is a really good point to try and maybe see if we could calibrate our system to a validated instrument. I do think that was one of the big limitations of this, and quite frankly, a lot of retrospective studies in RA.
Yeah. So just to explain it, you said that remission was 0, mild was 1, moderate was 2, and severe was 3. And then you sort of averaged that and followed it over 12 months. Tell us
Right,
about
yeah.
the escalation, de-escalation.
Right. So that's kind of in a similar vein. We kind of tried to convert that into a numerical score, where, we would categorize at each patient for each visit if their, rheumatoid arthritis therapy was the same, de-escalated, or escalated. And that's just based on, whether they had a dose increase or addition of a new disease modifying rheumatic therapy, or addition of steroids would be considered an increase, for example. Or if they were able to decrease a dose or, withdraw a therapy, that would be a de-escalation. And to kind of get that into an analyzable form, we similarly attached a value to each one of those, de-escalation being -1, I think, and same being 0, and escalation being +1. And so then we were able to kind of sum up all of those scores across all time points for each patient to get an average therapy change score.
Okay. And so tell us about the baseline patients, the differences between treatments and controls that were significant, table 1.
Yeah, so table one, there were some significant differences. I will just start off by saying, age and sex did not differ significantly. Seropositivity did differ significantly. It was a bit higher in the control group. I'm not quite sure why. Interestingly and possibly relevantly, the percentage of white patients was much higher in the treatment group. And that may speak to discrepancies in, treatment of these with these new medications between white patients and Black, Hispanic, or Asian patients here in the US. There has been data on that showing that there's disparities in medication uptake
Would it
based
be an
on race.
insurance issue?
It could be, definitely could be an insurance issue, could also reflect, trust in the medical system, cultural biases. But, in theory, in this study, all of the patients were prescribed the GLP-1. So I don't think we're picking up a difference in prescription. It's something other than that. But yes, very well could be a difference in insurance based on the patient population.
Okay.
Um, and then, as you had mentioned, there is a significantly higher proportion of patients with diabetes in the treatment group. And, we kind of expect that because that's one of the main indications for GLP-1 receptor agonist therapy. So we did we adjusted for that and when we did our data analysis, but that is a significant difference between the groups.
So tell us a little bit about your results and what you found.
Yeah, so we have some, what I think are promising and intriguing results in the patients who, in the treatment group, the patients who were prescribed and took the GLP-1 agonist therapy. They had a relative decrease in their rheumatoid arthritis disease activity, a decrease in their pain, reported pain, as well as a decrease in several of their cardiovascular risk markers when compared to the control group, which is patients prescribed but who did not take the medication. So we were excited by these results.
But if I look at table two, when you look
Hmm.
at the RA disease activity change in the treatment group, 30%
Hmm.
got better, 40% stayed the same, 30% worsened. And the
Yep.
actual score difference, is it clinically significant, a change of minus 0.03? Is that, it's means,
Right.
and I just wondered if medians would give you a better feel for what happened in the whole group. Is that a
Right.
clinically significant difference in score for disease activity change?
Yeah, that's a great question. And while it is statistically significant, I don't think I can say that it's clinically significant. Also because as we were talking about before, this is not a validated, disease activity scoring system. So while we have, minimal clinically significant differences for CDAI and for DAS, we don't have that for, for what we did here. So,
Fair enough.
I definitely agree with you. It's statistically significant. I would hope it's clinically, but we would have to do, a prospective study would be really the ideal, a randomized prospective study using validated markers to confirm.
Yeah, and you can say the same about the pain VAS because it changed a mean of minus 0.6 centimeters compared to plus 1.3. And you'd argue, is that clinically significant as well for pain? And
Right,
I only bring it up because you make quite a strong point where you say um, that significant improvement in activity, pain, and cardiovascular risk profile. So that's kind of a strong inference that the clinician would take away with
mhm.
those changes. So it's hard to know. Clearly, weight loss changed significantly,
Yep.
minus 4.5 kilos versus 1 and 1.2. The changes in ESR were very small. ESR change of 3, is that clinically significant?
Hmm.
And you didn't see any differences in the escalation or de-escalation at all.
Right,
So
right.
um, it's difficult to know whether medians would be difficult to means. Any other points from your results that we should know about? The lipid changes, the hemoglobin A1C, of course, changed significantly. What other,
Right,
which you'd expect with a drug developed for diabetes? So
right,
what
right.
else, what else do you think was important from your outcomes, both treatment versus control?
Yeah, I think we covered the main things. Those are very good points, and I think that this study is really kind of more of a jumping off point and a hypothesis generating. It's a retrospective study. We would love to have to do or to see a prospective, interventional trial to really solidify these findings. But they do kind of point us in a certain direction that I think other studies are also pointing in. Um, but no, I think we kind of touched on the main things, really, the disease activity, the pain, and then also, the lipids and the A1C and weight.
Yeah,
I do think those are also kind of a good check just to, make sure that we're seeing the things that we should be seeing with these
yeah,
medications. Um, but
yeah.
those were the main things that we found.
And you also say that no association between the weight loss and the outcome variables except A1C and blood pressure. So that's a bit tricky. Let's
Yeah.
talk about safety because
Mhm.
30% discontinued their treatment in the treatment group. And you comment that it's both GIT, which is common and a nuisance, and insurance issues. I just wonder how much of that was insurance issue and how much of it was GI intolerance, because 1 in 3 is quite a lot.
Yeah. And we don't have perfect data because of the retrospective nature of this here, but we know that 1 in 3 ended up discontinuing, and what we could find, about 15% of the treatment population had GI side effects. And so while those are not perfectly, compatible, I would, there is a 15% probably around there, portion who discontinued for other reasons. And we don't have exact numbers on how many it was for insurance or for other side effects, but GI side effects and insurance were by far the most common, reasons for stopping. And
Okay.
we did actually see kind of a higher, even 15% who reported GI side effects is a little bit higher or significantly higher than reported in clinical trials, which may point to, in real world use, maybe, is it more of an issue than was seen in the clinical trials, but it was definitely a significant proportion.
And could you again highlight what cardiovascular disease risk reduction parameters the treatment group had?
Yeah, absolutely. So in addition to weight loss, they had reductions in total cholesterol. And let me just make sure I'm saying all the correct things here. Um, they had reductions in, acute phase reactants, ESR, CRP, also low density cholesterol and triglycerides. But this was, just want to clarify, this is changes we saw within the treatment group. Not all of these changes were significant compared to the control group. The significant differences comparing the two groups was total cholesterol and A1C.
Okay. So excellent diabetes control or improved diabetes control. Thanks. So what would you recommend as a take-home message for the clinician? It's a retrospective, it's got the limitations, as you pointed out.
Mhm.
Where are you going to take this research, and what should the clinician take home from this particular study?
Yeah, those are great questions. So I think the GLP-1 receptor agonists are quickly becoming a another tool in our toolkit. Right at this time, they're approved in the US at least, for patients with obesity and associated comorbidities and diabetes. So it is something to think about, in our patients with rheumatic disease who have these comorbidities, which are indications for GLP-1 agonists. I think it's a tool to think about, and it very well possibly could improve aspects of rheumatic disease. At this point, we do still need to see, prospective trials to really clarify the effect on our diseases in rheumatology. But if you have a patient, with obesity and rheumatoid arthritis, it is something to consider if they have not already, if it's not already been considered to start this medication. And I know a lot of rheumatologists may not be comfortable with these medications. So, I mean, it would also be perfectly reasonable to refer to nutrition or endocrinology for an expert opinion on whether or not a patient might be appropriate to start these.
Excellent,
But
thank you.
oh, yeah, of course.
Yeah, yeah. Sorry, one thing I should have asked. You chose BMI of 27 for obesity. Is that a US thing? Because we tend to call it 30 here.
FDA indication at this time for these medications is a BMI of greater than or equal to 27. But
Okay,
yeah, so that's the reason why we did it. That is
excellent,
not,
excellent.
yeah, yeah.
So, any final comments before we wrap it up?
Um, I just think that this is a very exciting finding, but like we've gotten at with the conversation, we definitely need prospective studies to confirm these findings.
Yeah,
And also want to highlight just things to be aware of when prescribing these medications. Most significantly the GI side effects. And another thing is, the patients in this study most of them didn't even achieve the target dosing of these medications due to, side effects or other insurance or other things like that. And so it would be interesting to see in a group of patients who were able to actually achieve the target dose for weight loss, if we might see even stronger results or effects on disease activity and cardiometabolic risk.
So your next study will be prospective, full
Yes.
doses
Yes.
with validated disease activity scores.
Yeah,
Excellent.
exactly.
So,
Yeah.
because I've been very interested in this area ever since a lovely Canadian study presented at ACR, where they took 10,000 patients with immune-mediated inflammatory diseases. Those on the GLP-1 agonists were compared, who happened to be diabetic, so they all got it.
Mhm.
um, Compared those with the patients who weren't on the GLP-1, but the same clinical situation, and they showed quite easily less death, less stroke, and less heart attack. So I've been recommending this to my patients with a BMI over 30, even
Yeah,
if it's just for 6 months, lose 15 kilos, then fight to keep it off because it'll come back. And many
right.
people can afford it because it's not that crazy expensive here in Australia compared to many other countries around the world. And I think Philip Halliwell in the UK, last time I spoke to him, is starting a prospective GLP-1 study in psoriatic arthritis
Yes.
to
Yeah,
marry with your prospective study in rheumatoid arthritis.
yeah.
Excellent. So thank you
Yeah.
again for your time, David. We greatly appreciate it. If you'd like to know more
Likewise.
about this paper and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available at imidforum.com. That you can get the full paper in ACR Open Rheumatology, so you can have a look at the study in detail. Please subscribe to this podcast on Spotify, iTunes, or other podcast media. Let us know what you think. You can watch this on YouTube. And finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the new immune-mediated inflammatory disease content coming soon in 2025. So thanks for your time, David. Greatly appreciated.
Thank you.